Welcome to Trial Site News podcast series. Today, we are thrilled to have Dr. Laurence Heifetz with us today. Dr. Laurence is a board-certified medical oncologist and an expert in cancer services and centers and their related clinical care and quality models. He has served on the board of directors for Operation USA, Geriatric Oncology, Consortium Tower Cancer Research Foundation, Americans for Peace Now, and the Foundation for Mideast Communication, and most recently, the founder and medical director of the Gene Upshaw Memorial Tahoe Forest Cancer Center, located in Truckee, California. So, Doctor, welcome.
Thank you. Glad to be here.
The pleasure is ours. So, a little bit of backstory before we deep dive into the topic at hand for our audience. As Ms. Cohn's Emery's piece in Targeted Oncology explained, residents residing in Truckee area within California had few options for cancer care and absolutely did not have any access to advanced clinical research programs. Dr. Laurence worked to change that after moving from a position at the prestigious Cedars-Sinai in Los Angeles for a slower, more peaceful, and higher quality of life in the mountains. Heifetz found that there were no cancer services for a community of 50,000. And ultimately afforded the opportunity to build a cancer center based on a rudimentary program launched in 2006. The community put so much commitment, passion, and hard work that momentum and good decision-making led to the first freestanding cancer center opened in 2012. So my question then for you, Laurence, is we really enjoyed first learning of your story, moving from Los Angeles up to the Sierras. In hindsight, are you glad for the move?
Hell yes. This was at the end of about 25 years of practicing at Cedars-Sinai. It was a wonderful experience. I grew up in Los Angeles. I knew it well. And it was like, what was I going to do with the rest of my life? Did I still want to go to all those fancy restaurants, or did I want to really shake it up? So my wife and I, who's a radiation oncologist, we said, you know what, why don't we really have a major change? So we said goodbye to our practices and moved up to Truckee, where we thought we'd, ride horses and ski full time. That lasted a short period of time because there was a real need for advanced services up here. So no, do I regret it? Do I miss it? I'm not at all. I do have grandchildren in Los Angeles, so we go down there a lot. But it is wonderful to be up here in the Lake Tahoe area.
Well, we're glad to hear that. Now, when you arrived north, did you find materially different levels of healthcare resources and assets available for the local community?
Yes. There is one hospital up here. It's called Tahoe Forest Hospital. It's a 25-bed critical access hospital, primarily orthopedic surgery, primary care, OB/GYN, and pediatrics, with a smattering of medical specialties. 100% of cancer patients had to out-migrate to either Reno, Nevada, which is about 45 minutes to an hour and a half from the lake, based on what area of the lake or the mountains you're living in, to Sacramento, which is about 2 hours away. So in Los Angeles, Cedars-Sinai is almost 1,000 beds. It has 60 oncologists on staff. When I left, we're about 4 miles from UCLA, 5 miles from USC, and about 12 miles from the City of Hope. Those are all NCI-designated comprehensive cancer centers. So that's about the greatest experience in the disparity of cancer care that one could walk into, because there were zero services up here. And back in Los Angeles, we had a plethora of opportunities for our patients. That didn't mean that the quality of care for what was given up here wasn't perfect. Okay? It was. The doctors here, the quality of the staff was excellent. The services that were being offered, though, were restricted by which doctors were up here. So the hospital was extremely flexible and welcoming to opening up new opportunities.
So we know a little bit about how you got into telehealth, but could you share with the audience in more detail the process of incorporating telehealth into a broader healthcare delivery strategy?
It was almost a condition of being willing to see a cancer patient up here that we develop a telehealth capacity. I came from a practice of 9 medical oncologists. It was called Tower Hematology Oncology Medical Group at Cedars-Sinai. We had tremendous backup, and I had never been solo. So the idea of being up here alone was extremely scary to me. Mm-hmm. That meant I really needed to have a meaningful relationship with an academic thought center. So there are 3 in the Northern California area that are NCI designated comprehensive cancer centers. And that's Stanford, UC San Francisco, and UC Davis. And in decreasing levels of institutional arrogance, UC Davis was the most open towards, hey, yeah, we want to develop, we want to increase our telemedicine capacity to manage the populations in the Central California Valley as well as the Sierra Nevada mountains. So it was a serendipitous relationship between the UC Davis telemedicine group and myself, along with a couple of other institutions in 3 other areas of Northern California. So we formed a UC Davis Cancer Care Network. Now, our little organization was owned by our hospital. We didn't own anything with UC Davis. They didn't own anything with us. It was a handshake, let's do the right thing kind of relationship. So we started this experiment with what's called virtual tumor boards. It cost my hospital about $100,000 to convert a little conference room into a very high-tech conference room with 2 monitors on one wall and a camera in between those 2 monitors and a table that would seat 12 people. And we decided to meet with the UC Davis tumor boards on a daily basis. So how do you do that? The UC Davis tumor boards they've got all these disease-specific tumor boards that meet once a week or every 2 weeks. But 4 of those tumor boards make up 80% of all cancer patients. And that's breast, colon, lung, and prostate. So I figured if I'm going to be starting a program up here in the middle of nowhere, let's get super good at those 4 diseases, that 80% of cancer patients. And that actually goes along with the Pareto principle of the 80-20 rule. That means 80% of the work is done by 20% of the people in an organization. It's a business model, and it's almost like psychological business reality, but there's a biologic reality to it with cancer. Mm-hmm. There are about 20 different cancer subheadings, but 4 of them, breast, colon, lung, and prostate, or 20%, occupy 80% of all of our patients in the United States. Wow. So let's get really good at those 20% of diseases to take care of 80% of our patients. And then the infrastructure at our little hospital will have been built so that we'd have better understanding of how to process specimens with pathology, of the requirements for reading diagnostic imaging studies, of the necessity for the emergency room to be tooled up for dealing with myelosuppression and fever. All of these elements would have been built for the big 4 diseases to take care of all the rest of oncology that would also happen up here. That was very long-winded, right. But that actually is the reason why we had to have a way for me to have a face-to-face relationship with thought leaders. So the UC Davis guys got together and said, okay, we're going to move those big 4 tumor boards to noon, so that every Monday noon was GI, every Tuesday was GU, every Wednesday was thoracic, and every Thursday was breast. And I get to go skiing on Fridays.
That's always a good plan.
Exactly. So the relationship then was a very face-to-face relationship from doctor to doctor. I'm not talking about doctor to patient right now. I'm talking about doctor to doctor. So every day we got smart at lunch, and the we grew within a few years to 4 of us from just myself alone. We blew through all of our predictions of how many patients we would be seeing, because the transparency of having this academic relationship kind of filtered through the backwoods over here, and people felt extremely secure coming here. And that's the big fear that has to be addressed in a rural setting compared to an urban setting. Are you going to get the state-of-the-art care? So telemedicine was integral, not for me to talk to a patient, but for me to talk to other doctors.
Right. So for those that are looking at telehealth deployment strategies, what kind of challenges should they be aware of, and how are they overcome?
So the usual use of telehealth is between a doctor and a patient.
Right.
And it's usually it started off with the rural reality created the need. So all of these little hospitals in the middle of the mountains and the Great Plains have already developed telehealth relationships with big city hospitals. So if you have an ICU problem, you can communicate with an infectious disease specialist at the big major medical center. What we felt, what we experienced in our little place, was that we had a lot of patients coming from even farther away to come to see us, and we had like an hour to see us in a snowstorm. We got comfortable in front of cameras, so we installed cameras in little clinics out in the mountains that were owned by other hospitals, and a nurse practitioner would be there, and our patient would be able to come for a day 8 follow-up chemotherapy visit, or a 3-month breast cancer check, and they would be seen by me at my desk through it's like a Zoom meeting, but it's a HIPAA compliant meeting.
Right.
And the nurse practitioner would actually do the physical exam. But the vast majority of oncology doesn't require physical exams. The vast majority of oncology is face-to-face with a patient, and face-to-face with telehealth works just fine. I will tell you that quite a few patients said, "Hey, I want to drive in, Larry, because I miss the hugs." But for the most part, the patients very much appreciated that. So the first thing is patient buy-in. Will patients feel comfortable seeing a doctor? Well, if you look at the average doctor visit today over the last 10 years, the computer has been helpful, but also has been horrible.
Yeah.
Because now you've got doctors looking at the screen, and some IT tech could easily have put the screen 90 degrees or 180 degrees away from where the patient's face is. So you're turning your back to the patient, or you're turning your face away from the patient while you're asking the patient questions and entering data into the computer. And your patient's sitting right next to you. Instead of looking at your patient with a piece of paper in front of you so you can get the patient's eye. So the doctor-patient relationship has been altered in a physical, in most of our physical exam rooms. Actually, with telehealth, you're looking in the patient's eyes, because you've got the patient right. You move the patient, a little thumbnail of the patient on your screen, right up to where the camera is on the top of your monitor, and you're looking in that patient's eyes all the time while you've got the imaging and the EMR up that you are entering data into. But your face-to-face relationship actually is functional, and that eye-to-eye communication is on a human basis very, very necessary for patients to feel what's called presence. A doctor can have presence by looking the patient in the eye, or a doctor and can have an effective, a very effective, warm experience with a patient in 10 minutes. A doctor can spend a half hour not looking at the patient, just looking at the computer, and the patient is completely dissatisfied. So eye to eye is a human experience that that actually today can be better with telehealth than the way most of the exam rooms are set up due to this thing called a computer screen. Is that clear?
That's absolutely clear. So, how do you think, and based on this experience, and you've already made some major strides, how do you think we can continue to improve rural healthcare moving forward?
So we need really good technology. We need high-speed internet connectivity everywhere. Fiber optics, any investment that can be made to truly improve, hitch a ride on Amazon and Netflix and stuff like that, so that and the streaming services, to hitch a ride on technology, so that we can get everybody out there in the United States a high-speed connection. We have to make it real easy for a patient to do. So ultimately, instead of a telehealth visit being the patient going to their local clinic and having a visit with their doctor remotely, they should be able to have it at their home. So this would be the next iteration of telehealth is the 21st century house call. And it's almost like going back 150 years where doctors did nothing but house calls. Then the big question is there a way to get an effective experience for me to do my job as a doctor without physically touching my patient, without physically listening to their lungs? Is it really necessary for me to look in their eye, do a fundoscopic examination, and look inside their ears, look down their throats? Is all that totally necessary today? Yeah, it probably is necessary on certain occasions, but on the vast majority of experiences between doctors and patients, it's really not. Now, that's going to require all kinds of scientific testing, but I'm just going to lay it out there that I think we could redefine how health is maintained without being hamstrung on the rigidity that we were taught in medical school for the past 300 years of what a proper examination entails. Okay? So yeah, once a year the patient probably does need to come in to get a proper physical examination.
Right.
If they have a complaint, it may be functional for a doctor to listen and eyeball the patient, because a hell of a lot of information comes from facial communication and physical nonverbal communication that we're very sensitive to, both patients and doctors together. We can get a lot of functional information out of that televisit, much more than a telephone visit, that almost approximates a laying on of the hands visit. And then if you need to lay on hands, you may actually say, I'm going to send you for a CAT scan and on your way in to see me day after tomorrow. So I'm going to send you for a blood test. Okay, Jack, I'm going to send you for a blood test and see me in 3 days. We're going to move the ball forward, and then obviously bring the patient in for a physical examination if the physical examination is necessary.
Right.
It's a real hard thing to prove because there are all kinds of roadblocks to that. There's tradition, which is the greatest roadblock.
Mm-hmm.
There are rules and regulations of billing, this horrible thing called a billing code for Medicare and the private health insurance companies to justify what you are doing. Is 20 minutes on a telehealth without a physical examination as meaningful as 10 minutes with a physical examination? How are we going to account for this experience to the people who need to account for it, which are the bean counters of the world, who have created these horrid electronic medical records based on accounting instead of based on patient care? So we've got a billion roadblocks to this concept, but functionally, the opportunity for creating telehealth house calls has got to be jumped on. And the current COVID-19 crisis is the lemonade out of the lemons from this crisis is that it's actually happening right now, because we just can't bring the patients in for routine visits into the office, and so we don't want to even bring them into local clinics. So we are doing this right now, and there are companies tooling up to break through these roadblocks.
And it might be a way to break through the bureaucratic mess eventually and prove the concept.
Exactly. Exactly. One of the things, Bush pilots in Alaska came up with the need for certain navigational tools and weather tools that are in 747s today. So those of us out here in the mountains actually can come up with the necessity to reach out to our patients that may be applicable all throughout society.
So let's talk then about improvements. For now that you've developed your current network, what kind of improvements are you seeing in the outcomes since you deployed your network?
So the first element of the network was the virtual tumor board. The most meaningful element of the network was that this small hospital with this small medical staff had an almost daily interaction with an NCI designated comprehensive cancer center, UC Davis. That gave us the sense that we were maintaining this, that we were able to practice at the state of the art. We knew what was available. We knew which clinical trials were available. We tooled up to be able to deliver that. The second part was that we then created these telemedicine outposts, and we created 4 of them. And some of them were an hour and a half away, as far as an hour and a half away. The outcome was that by having scheduled telemedicine visits, which were no different than a regular doctor's office visit. So I could see a patient at 10 o'clock in my office, and at 10:30 I had a telemedicine visit. And my partner could be seeing patients in the office and telemedicine visits, and we could have simultaneous telemedicine visits with different locations, and it was no different than a regular scheduled event. You didn't have to tool up and get all kinds of bureaucrats involved. You just scheduled it, and it happened. The outcome was that after about 10 years, we saw our first patient in 2006. Telemedicine started. The virtual tumor board started in 2008. Telemedicine clinics started in 2012. By 2018, we had gone from 100% out-migration to 62% in-migration. Wow. That means that we have captured the vast majority of patients within our 50,000 patient catchment area, but the majority of our patients are coming from outside of that area, okay?
Yeah.
Why would they ever do that? It's because the respect for the patient of being able to make it available for them to stay at home, even if they don't want to, they know they can, and the transparency that the state of the art is available because we are connected to an academic set of thought leaders has resolved that sense of insecurity that patients in remote areas have. Am I getting the state of the art? And we can't say, and we won't say, that we're any better doctors than any of the other communities they're driving past, or that our patients live one day longer. We can't say that at all. We can say that we feel secure and our patients feel secure with this system.
Well, it's the experience that they're getting, not just the care.
I think you nailed it. The patient experience is what drives what drives a medical practice. And that's if you have a situation where patients have free will as to where they can go. And thankfully, with Medicare, and the vast majority of our patients are Medicare patients, all cancer patients are heavily skewed towards the Medicare age group. They've got freedom of movement, so they can pick and choose where they want to go.
So let me switch this up a bit, because you mentioned clinical trials. So what about clinical research? Now, as you are affiliated with UC Davis, are those in the community diagnosed with cancer getting opportunities to participate in studies, and are they embracing these opportunities?
So when I was at Tahoe down at Cedars, we formed a research foundation because we knew very well the patients. If you're not participating in clinical trials, you are you're missing an opportunity to demonstrate that your patients are getting the state of the art. Patients don't all go on clinical trials. In the United States, 3% of the patients of the adult cancer patients go on clinical trials.
Right.
But having the availability of clinical trials keeps us smart and makes it safe for the patients to know that we will either deliver the trial at home or send them to wherever the trial is necessary. In Los Angeles, you rarely had to go farther than 5 miles from wherever you lived to get to a place doing clinical trials. Now, we moved up here. What the hell is a clinical trial up in a little mountain place? People didn't know from clinical trials. So we tiptoed into it, but that was an element of the UC Davis relationship. And it was to their interest that we do this. So one of the what's in it for me, for UC Davis to care about a relationship with Tahoe Forest Hospital out in the mountains, is that we provide patients to their clinical trials. We became clinical faculty at UC Davis. We brought on a clinical research coordinator who was completely electronically connected to the research department at UC Davis. And we built out the infrastructure to be able to follow through with phase 2 and phase 3 clinical trials. We don't have anywhere close to the capacity to do a phase 1 clinical trial. So the raison d'etre of an academic center is creating new knowledge, and that is done through clinical trials. We helped improve their clinical trial accrual rate. As it happened, our own clinical trial accrual rate once things got tucked in was almost 10%. That's extraordinarily high. So the willingness for patients to participate in clinical trials is real. I mean, just think about what it would take right now in the COVID-19 experience for a patient to be offered a clinical trial for therapy. How many patients do you think would sign up? I think the vast majority would sign up. Do whatever you need to do, doc. We have the same kind of feeling with cancer patients because the fear is there, unfortunately. But that actually is one of the things that drives enrollment in clinical trials. Anyway, having a clinical trial capacity helped the patients feel that we were state of the art, and you actually had to deliver on that. You don't want to make it make believe, you have to make it real.
Right.
So we delivered on that. And that, I believe, is sort of like the proof of the pudding of why the in-migration rate through this system turned out to be so positive.
Absolutely. So you mentioned cancer care earlier. So tell our audience how you see telehealth being used to address disparities in cancer care.
If you think of the model that we put together, we have a relationship with Thought Center that is 100 miles away. Okay?
Mm-hmm.
And then we have 4 nodes coming from our location of telemedicine clinics that also are 50 miles away. So think of your internet connection, and you're wirelessly on your laptop, and you decide it's a sunny day and you decide to go outside to work on your laptop, and your internet signal decreases and you walk too far, and the internet signal dies, your Wi-Fi signal dies. So we're postulating that knowledge acts the same way, the inverse square law, so that knowledge decreases, or rather the state-of-the-art knowledge decreases the farther you are away from a thought center. If that's the case, then the application of this system of telehealth from the thought center to a node, and then from the node out into the periphery, will decrease that disparity of health by definition, because the level of knowledge will not fall off as far over that distance, way out into the middle of nowhere. Can I prove it? No.
So how do we get academic centers and community facilities to communicate better between one another? Care coordination?
Yes. So one of the most important elements the analysis of this idea was figuring out what's in it for us and what's in it for them, being extraordinarily selfish about it. What's in it for UC Davis? Why would they go through the work of actually, it was really hard to get the tumor boards to move from 7:30 in the morning or 4 o'clock in the afternoon, to coordinate, to be willing to make that change. I mean, doctors don't want to change. So then they had to actually have remote facilities on their screens, and they're not used to doing that. They're used to just talking to themselves and their tumor boards. They didn't want to necessarily have to deal with a bunch of local doctors in small facilities. So what caused them to want to do this? Or what made them feel secure continuing to do this? One was absolute increase in clinical trial accrual. Two, if I've got a patient with lung cancer and we are not doing advanced lung cancer surgery here, and I've presented the patient at thoracic tumor board at UC Davis, what would ever cause me to send that patient for surgery to UC San Francisco or Stanford or UCLA or any other major city? Nothing, because the guys on the tumor board already know my patient. Plus, I've got a fast track. I've got a back door. I can get the patient in to the academic center rapidly. The doctors on the necessary doctors on the team already know the case because the case has been presented. If you try to get a patient into an academic center, it can take 3-4 weeks, and you got all these roadblocks that happen. This shortens that. So the academic center, the thought leader, gets the advanced cancer patients. They get the big pancreatic cancer surgeries. They get the sarcoma surgeries. They get the thoracotomies. They get the brain tumors. They get the stuff that we in the small towns shouldn't even dream of doing. That actually improves their service line, and it improves their bottom line as well. Lastly, what's in it for UC Davis is that the NCI Comprehensive Cancer Center designation, the word comprehensive, requires demonstrating functional community outreach. And you don't get any more outreach than Truckee, California. So the health of this relationship helps them maintain their NCI designation.
Right.
That's what's in it for them. What's in it for us? Well, we went from nothing to something. We've got 1 million certifications from all kinds of organizations. We grew from one doctor, me, who just recently retired, to now 4 doctors. We've got community support to put together a 20,000 square foot facility with state-of-the-art radiation therapy and PET-CT scanning. We've become a revenue center for our rural hospital. And the revenue from our cancer program is what supports pediatrics, labor and delivery, and primary care, the real medical emergencies that are going on in our community.
Right.
So by building this, we've been able to help support our hospital that could have been another casualty in a long list of rural facilities that are closing their doors.
Now, you touched on this next question earlier, but how do we bring clinical trials to rural America or make it easier for them to come to us?
Well, to the extent that clinical trials are profoundly difficult to enroll on, that issue is at the level of the clinical trial designers. Don't ask me to endorse the wisdom of how the clinical trials have been made almost impossible to do due to the statisticians and bureaucrats in the system. However, if a system exists where you've got enough doctors in a local rural place who have a commitment to wanting to do this, the clinical trial support can come from the mothership, we'll call it UC Davis. so that all kinds of questions about compliance and basically enrollment compliance and timing and all the elements of getting the patient in can be supported. It's nothing more than being awake to the presence of those trials and having the local facilities engage the patients so that they are aware, hey, you don't have to go any farther, we've got it here. And then we also have to be able to explain to those patients that, this trial really requires you to drive to San Francisco or to fly to Houston. So there may be times when we have to do that, but it's letting the patients know that it's available. Well, how do we know that those trials are available? We become knowledgeable in that due to the everyday experience with these virtual tumor boards. Because we can't keep up with the knowledge base changing so rapidly. But at the tumor boards, even if you don't have a patient to present, you're going to go eat lunch there anyway and participate. And you're going to learn about these trials and it keeps you mindful of the presence of those trials.
On a last note here, we know more and more clinics have been closing in rural America, thus making it harder for them to access care in general. What do you see as the best possible solution to this problem?
That's a really hard call. I do think that technology can allow for a redefinition of how a rural health clinic delivers care. And if that can take place, you could imagine the bricks and mortar expenses of hospitals decreasing, while the capacity to take care of an increasing number of patients in a rural setting increasing due to redefining what a doctor's visit is by the telehealth experience. I don't know how to solve the closure problem of some of these small hospitals. I know it's hard to get doctors into some of these smaller places, these much more remote places. Not all these places are as cool as Truckee, California, where we've got 5 ski resorts around the corner. So we don't have any difficulty recruiting doctors to want to be up here. But there are other towns that don't have the recreational panache and really need the care. So I do think that by redefining the definition of a healthcare facility and enabling these telemedicine house calls, you may be able to completely change how care is delivered, and it'll be these clinics. While some may close, a new, more mobile, more functional entity may be created.
Well, thank you so much for taking the time, Dr. Laurence. It's been an honor and highly educational to talk to you today.
I appreciate it. This has been great. Take care of yourself. Stay safe.
Thank you. Thank you so much for joining us. So much.